She's a doctor.
Hi, I'm Dr. Dovek, and she's a dietitian.
Hey, I'm Hannah Schuyler, and together we are
the Doctor-Dietitian Collab. Well, ladies and gentlemen, boys and girls, we have our first guest in the house today. Dr. Susan Case, a gastroenterologist who has a lot of specialties. And today we are talking about hot girls do, is this true? Hot girls do poop?
Hot girls poop.
Absolutely. They sure do. Thank you guys so much for having me on your podcast. I'm so honored. No one told me I was your first official
Our very
guest.
first guest.
Wow, that is a lot of pressure right now.
No, we're way fun. You want no pressure.
I know. We are so excited to bring somebody else into our little humble abode in here and into our room with the pink lights and all of the fun that we are. So let's talk. What is a gastroenterologist anyway? What do you do for a living?
First of all, gastroenterologists do not play with poop, number one. We like to talk about it, but
people
not really
think you play with it?
They really do.
Oh.
They really do. So for example, we do colonoscopies. That's where we pass the scope through your colon. First of all, sometimes for screening colonoscopies to make sure you don't have colon cancer. And then we do it for other reasons, for diagnostic reasons, if patients are having complaints, things of that nature. So sometimes we get patients that decide they want to ride dirty and think that that's going to work for us. But that basically means an unprepped colon. And we don't like unprepped colons because we like a clean colon, a colon that we can eat off of, essentially.
Oh, yeah. That sounds yummy right about now. So, okay, how do you guys, so I know that there's the bowel prep, but what are, like, in today's day and age, because I know you don't drink the huge gallon of Go Lightly anymore.
You can't. Yes. Well, first of all, it varies. It depends.
Okay.
If you have normal bowel movements, so we like to do what's called the Miralax and Gatorade split prep. It's a little bit more palatable.
Okay.
Okay. But afterwards, people come away hating Gatorade, unfortunately. And then if we have patients that have struggling with constipation, they're doing a 2-day prep and that whole gallon.
Oh, really?
Go Lightly. You got to get it out. Listen, nobody wants to do a clear liquid diet the day before, 2 days of clears and changing their dietary habits and then drinking all that and coming in and be like, sorry, it's dirty. We can't do it. And they're like, what? I'm never coming back.
Wow. So, okay, I actually thought that the Go Lightly thing was a thing of the past.
No.
It's
still relevant
oh my gosh.
and used in this day and age.
Oh, so, okay. So let's educate our listeners because I guarantee we have a lot of hot babes who want to hear all about this right now.
Well, about the prep or the colonoscopy or the whole shebang?
There's so much to talk about here. There's so many things about poop.
There's so many things about poop. So poop comes in all shapes, forms, and sizes, and we like to refer to our Bristol Stool Scale, which is a 1 through 7.
Oh, do tell.
Oh, yes, we do.
I want the perfect poop.
You know, to have the perfect poop, you got to be right dead in the middle there, right in the middle. If you're 1, you're constipated. If you're 7, you're running like a river. So we want you right in the sweet spot, right in the middle. 3, 4, going, soft form, S-shaped, sausage-shaped stools, once a day or every other day. And you actually feel fully evacuated. That's important. Just passing something is not enough.
Okay, so there's different types of poop. And when should you be worried about this Bristol scale here?
Yes, you should definitely be worried if you have an abrupt change in your bowel habits. If you're seeing blood in your stool, that is what we call an alarm sign. So if you see blood in your stool, you need to let your primary care doctor know to refer you to your gastroenterologist so that we can do the appropriate labs and work up to make sure that we're not missing anything life-threatening, such as colon cancer.
So when you talk about like an abrupt change in your patterns, so like what are you talking about? Like you're always constipated, now you get diarrhea or?
So patients, first of all, everybody thinks that what they have may be normal, but when they finally come and talk to a gastroenterologist, we're like, that's not normal. Having diarrhea, having runny stools, flipping into constipation and then flipping back into diarrhea, you may have irritable bowel syndrome. So there's a lot that goes into diagnosing patients with regards to what's going on with their diet, with their bowel habits. So you start from the beginning, you get their history, what their baseline was, what are the respective changes, do their labs, and look into their family history, and then take it from there to kind of decide what's the next step. And most likely there's a colonoscopy in your future.
Lucky you.
Well, I mean, it sounds necessary, but you talked about irritable bowel syndrome, and I know a lot of our patients struggle with that.
So irritable bowel syndrome, the first thing I like to say is that irritable bowel syndrome and inflammatory bowel disease, IBD, are not two in one. A lot of people come in and will say, Doc, I have IBD. And I'll be like, well, how do you know that? Well, my doctor diagnosed. I said, you had a colonoscopy? No. Or they'll come in saying, I have IBS. So you can't use the two interchangeable. So IBD is an inflammatory bowel disease that is primarily an autoimmune-driven phenomenon that is kind of an interplay of a person who has the genes for the inflammatory bowel disease. It's an interplay of the environment and other exposures, and that bring the disease to fruition. And then with regards to IBS, which is irritable bowel syndrome, it is not related to such. It's a diagnosis of exclusion, where you can have either irritable bowel syndrome, diarrhea predominance, irritable bowel syndrome, constipation predominance, or a combination of the two. But in order to get to that diagnosis, you have to rule out the other related disease entities before you get that diagnosis. And a lot of times patients are not, unfortunately, having the full diagnosis because they come in saying, my primary care doctor diagnosed me with IBS. Okay, what was your workup? I just told him about my stools, and he said, I have IBS.
Oh.
That's it. That's the workup. And that's not the appropriate workup. It's a diagnosis of exclusion.
Huh.
Yes, and it's primarily highest in female population.
Well, same with our patients. 85 to 90% of our patients are also female. Mm-hmm. And is there a relationship to like anxiety, depression, gut-wrenching anxiety kind of like?
So when a patient has their formal workup and we come to the conclusion that their symptoms that they're having, saying, I have normal bowel movements, doc, and then, I don't know, for like a week, I get a flare and I'm having like rip-roaring diarrhea. Everything's coming through me. Then I flip back into normal form stools and I don't know what it is. What was your question again?
Just how is it related to like anxiety?
Oh yeah. So we talked to patients. So irritable bowel syndrome, they were like, well, what's causing it, doc? What are the reasons for the irritable bowel syndrome? So we talk about three different things. One, that gut-brain axis dysfunction. That's one. The second thing, is it something from a dietary standpoint that you're taking in? So that's where that infamous FODMAP diet comes into play. Yeah. And then thirdly, could there be a component that your respective microbiome is out of balance? So I am very conservative in my approach. I take it a very stepwise fashion. We start with the dietary and have them go to a nutritionist.
Dietitian,
I hope. Dietitian as well. And get the foundation, because if you want to do the FODMAP diet, which is actually a misnomer. It's not really a diet.
I've never heard of that.
It's actually an elimination. It should be an elimination diet. You want to go into that further?
It's a low FODMAP. So FODMAP is a fructose oligoside
I said so long.
FODMAP. It's like all these different sugar molecules. And so you basically eliminate them from the diet. And then a lot of times, and I don't deal with this, so there are people who specialize in low FODMAP and digestive
and that's their
health.
Expertise.
And that's their expertise.
Exactly.
But then you can try to reintroduce
and see which one is
there a specific one. But it's interesting because it's a lot of foods that we generally think of healthy as healthy,
exactly.
quote unquote healthy.
But here's the thing: that so many patients are getting placed on this FODMAP diet, but it's not a diet to be on. So they're excluding all these healthy things that they shouldn't be. It's an elimination diet. So they're coming, doc, I've eliminated all these things on the FODMAP. I'm like, no, you're supposed to be doing this over a very structured period of time. So when you are telling your patients to go and do this without the appropriate direction, it's a disaster, because now they're eliminating things that are good for them, but they have this misunderstanding that they're supposed to avoid all these healthy things forevermore, which is really unfortunate. So whenever I see a patient in the office, I try to let them they'll come in and say, I'm doing the FODMAP diet. I've eliminated everything. I was like, well, have you tried to reintroduce these things? Or like, no, I thought I was supposed to just keep them all out of my diet. And so then I send them to a nutritionist, dietitian who has the expertise to do the elimination diet correctly. And I have actually had a lot of successes where patients coming in, a person was having severe IBS constipation, and they identified that it was watermelon that they were having every day on their salad that was driving their IBS.
Really?
Another patient, avocado.
Really?
Another patient couldn't tolerate the green peppers, but could tolerate the red, yellow, and other ones. I don't know what's in the green pepper.
I don't know if it's
so strange.
Yeah.
Like you're like, he's like, for real, I can only, it would trigger their respective IBS. So yeah, we're really doing a disservice to our patients who are going online and eliminating healthy, nutritious foods that they should be having when it's really supposed to be an elimination diet.
Yeah. I mean, I think if I had to do an elimination diet as a dietitian, I would need to go see a dietitian.
Right.
I wouldn't know how to do it.
Me too.
Yeah.
I'm a gastroenterologist, and I'm like, I'm like, listen, let me be quite frank with you. I don't even know where to begin. So these individuals are trained. They know how to teach you, guide you, so that if there is a component of something that you're eating in your diet and it's one thing or more than one thing, wouldn't you want to identify it so that you could be over this?
Right.
So that maybe when you say, okay, now I've identified the things that cause me my rip-roaring diarrhea, but I love it so much, I'm just gonna suffer through it. It's like the dairy situation with lactose intolerant.
Lactose intolerant people love eating dairy.
Exactly, but you're gonna suffer.
Yeah.
But at least if you have that insight and understanding, it won't be so scary.
Or the forethought to take Lactaid.
Yeah, that too. Some people say it doesn't really work well for them. So,
well, I mean, geez, there's so many things. I have like a billion questions. First off, like, okay, how often should you even poop?
So I tell patients that you should be pooping at least every day or every other day, and again, feeling fully evacuated.
What happens if you feel like your rectal vault has not been fully evacuated?
If you're feeling like your rectal vault is not fully evacuated, so we have to figure out why you are not able to actually fully evacuate your vault. Is it because you're having some pelvic floor related dysfunction? Is it just because you're, someone today said, Doc, my poop pushing power is low, literally today.
Wow. I feel, I gotta come see you. It's amazing here. Okay, so then, what's that about?
Or they have like slow, or they have basically the transit time through their colon is slower. So once things go through your small bowel in a liquid format, they get into your colon, and your colon's job is to absorb water from that to give it its form. If it is taking a very long time to get through, it's going to drive that constipation, and then you're going to get to the rectal vault, sigmoid area, where we're supposed to store things, and that's supposed to trigger to our brain and say, hey, Susan, when convenient, it might be a good time to, head to the local restroom. But then patients can't go because they're constipated, and maybe it's because they have slow transit time. So we want to put them on some medications to help promote better transit time and also soften their stools.
So transit time, what would you say, like if I ate a meal, how long does it average should it be kind of coming out?
The meal that you ate should be coming out, gosh, off the top of my head, I'm not 100%
okay,
sure.
well, I don't even know.
There's a way you can try it with like a blue muffin.
Yeah.
Food,
you put like food dye in something. Like I've seen people, they're like, you can do it.
We're going to do a little experiment. We're going to report back to all of our fans.
How long?
Yes, but I'm sure you know that. Obviously, you probably know this very well. Like patients ask when they have gastric emptying study, emptying issues, transit time from the stomach to the small bowel of a meal should be almost completely empty within 4 hours.
Wow. I mean, and I think that is a lot of things in with diabetes and gastroparesis. And
yep.
Well, now thinking into, I mean, obviously people who've had bariatric surgery, we've changed that. But then thinking into some of these weight loss drugs that are slowing that motility, lengthening that transit time.
So here's something very, very interesting. I had a patient who came in to see me about having really bad abdominal pain and also really bad reflux, and like, doc, I just can't eat and I'm just uncomfortable. I'm miserable. And I'm thinking to myself, okay, maybe you have esophageal reflux, and maybe you're having some peptic ulcer disease, some maybe gastritis. So let's do an upper endoscopy. Well, before we go there, so looking into the rest of her history, I inquired, so you're on one of the newer weight loss medications? And she said, yes. And I said, how much weight have you lost? And said 40. She was very happy with the progress she made. And I was like, would you say that you have started experiencing some of these symptoms, like, since being on it? She's like, I'm not really sure, maybe, but it's probably since after. It's obviously after I started this, but not like immediately after. So I'm like, we're going to do an upper endoscopy. So we go and we do an upper endoscopy. There is like a huge food bezoar in her stomach, and I'm like, is this from this real, true delayed motility that these patients are going to start coming in with these food bezoars? Or it's
really?
Yeah, she's never had this issue before.
Wow.
It literally happened after starting the therapy.
What was it? A GLP-1 agonist? Was it phentermine? What was this
med?
It's
GLP-1.
Okay.
Yeah.
Wow.
So now I'm like, okay, what do I do? So I'm like, okay, I want you to go on a clear liquid diet, and I'm going to re-scope her and see if it makes its way downstream. So now it's just because she's really miserable, miserable.
How big is the bezoar?
It's encompassing her whole stomach.
Whoa, so that's huge.
It's huge. It's as big as the stomach. Like I insufflated the stomach, and there's this huge, long bezoar. I can't even see downstream past it. I can't see the part of the stomach that transitions into the small bowel, which is called the antrum of the stomach. I can't see it. All I see is the top and this huge log bezoar, which is all compacted. There's no liquid around it. It's just stuck.
Oh boy.
Oh my gosh.
I don't know. Have you heard anything?
Never.
I mean, now that these new weight loss drug medications are being more readily prescribed, whether through our gastroenterologists who are, involved in
like the gastric balloon and all that?
Yeah, the gastric balloon, things of that nature. Then our primary care doctors, and then we have wellness centers,
sure,
who are prescribing. Are we going to start seeing this more in the public? I don't really know the studies.
Wow, that is unbelievable.
Yeah, I don't know what to do. I'm like, do I tell her to stop it and see what happens? But now I've got this food bezoar.
Well, how are you going to get rid of that?
I don't know. Well, okay, there's patients that
oh, the hair thing?
The hair thing.
Yeah.
What's it?
Trichinosis?
No.
That's phobia?
It's where it's a type of where you eat your hair and you actually get a hair bezoar.
Yeah.
And that needs surgical intervention. Like you have to have a surgery. Is there something that we can give patients to break down the food? There has to be, right?
I'm like, can you give enzymes or something?
I know. Or are they going to need surgical intervention?
Oh my gosh. I'm just baffled by this. I have had to operate on a post-op gastric bypass patient when they have a food bezoar that is occluding the JJ, the jejunoplasty, the downstream wide-looking connection, because it kind of gets lodged there. Mm-hmm. But not in the stomach is huge.
The whole stomach.
Can you describe to the team, to everyone out there listening, how big this thing is then?
Oh my gosh, how big? I would say it's the size of, let's see, like a size of like a small Nerf football.
Oh.
I couldn't get around it.
Yeah.
I insufflated. I put air in the stomach. That's what we normally do. So we pass the scope from the mouth, go down the esophagus, past the end of the esophagus where there's the sphincter, and we go into the stomach. We put in air to start evaluating stomach, evaluating the small bowel, and then boom, I run into this huge food bezoar, which is most likely, it's like literally that big.
I'm blown away.
I'm blown away too. But I'm going to say, listeners, we're really big into the medical weight loss scene here.
Yes.
So I would not dissuade anybody.
I would not dissuade, but I'm just saying this is something that is interesting.
That's something we're going to keep our eye on this.
Yeah,
for
You
sure.
should write that case study up.
Yeah,
you could get published with that.
Mm-hmm.
Yeah.
I mean, seriously. So, I mean, all this stuff you're talking about, food bezoars and poop and going out with the colonoscopies.
Yeah.
Why did you want to be a gastroenterologist?
You know, there's everything for someone. I guess for me, I would say that when I was, so my brother was actually diagnosed with ulcerative colitis at 6 years old. So that really impacted me a lot. Then I went to medical school, and I still had a very, very high interest. And then I decided I wanted to do internal medicine because it offered me a wide array of subspecialties. And I decided on gastroenterology because my understanding through my brother initially, and then later in life, I too was then diagnosed with inflammatory bowel disease.
Oh, I didn't know that.
Yeah.
Oh,
Yeah.
So do you have ulcerative colitis or Crohn's?
Ulcerative colitis.
You have it too.
Mm-hmm.
Okay.
So when patients
say, talk about that.
So you know, it really gives you a very unique perspective. I always say, God doesn't give you something you can't use in the future. I'm never a victim. I'm always a victor in any situation. So take whatever challenges and turn it into something beautiful, and try to have an impact with what I've gone through and help other people. So it's impacted me that it's actually initially my brother's ulcerative colitis had a strong impact on me, and then I became the patient. So I know exactly what patients are going through, what families are going through. I'm on both sides of the table. So when a patient is looking at me and saying, Doc, I'm really scared to start this biologic or this therapy, I don't necessarily start my conversations, but when patients are being really open and transparent, I say, let me reassure you in the sense that I was actually diagnosed at 16 years old.
Wow.
Wow. Okay. I mean, you have a great Instagram presence.
Yeah.
Go ahead and do a shameless plug there for them to check you out on Instagram.
At DoctorXDietitian, and my last name Case, Kais. So I talk a lot about educating the patients and patients with IBD about evidence-based information that's impactful for their inflammatory bowel disease. So I take these studies and I dissect them and make them more palatable and understandable for a lay audience, so they can also be up to date with the research, the findings, as opposed to, not to minimize other Instagram profiles or anything like that, but my platform is just to make sure that you're in the now with everything that's going on, so you have an understanding.
I mean, I think it's awesome. And I think for a lot of our patients, whether they have inflammatory or irritable or just plain old constipation, we get every second
all the time.
Because when they follow the high protein diet, also they have. But what's your, like, I'm sure you have a spiel on constipation.
Yeah.
I'm not pooping every day. What should I do?
So when you're not pooping every day, you should come talk to your local gastroenterologist so we can figure out a bowel regimen. So first of all, I take the most conservative approach. So we want to, number one, are you drinking enough water in the day?
Oh, yeah.
Are you eating enough fiber? And are you actually exercising that you're actually promoting gastric, motility in your GI tract? So if you're not, let's try to see if we can correct those things before we start throwing a lot of things at you, right? So let's say they are doing all those things. So then my next step is to go to Miralax, which is basically a medication, a powder that you mix with any cold liquid. And the purpose of the Miralax is to draw water into the colon, which is like we spoke earlier, the colon's job is to pull water out, right? And now we're pulling it back in to help promote things to slide through the colon a lot smoother and much more easier. Aside from that, if that doesn't work, then we add on a stool softener. Let's see if we soften up the stool and continue the Miralax. And remember, the Miralax is non-habit forming. It's not going to make your bowels lazy. You can titrate up on that. It's very safe. And I tell patients they should do a dose for a week and see if that's actually getting you to one good bowel movement daily or every other day. If it's not, go up until you get there. If you develop diarrhea, you need to cut back. So only you know based on what you're eating and what your bowel habits are like with the medications. Now, let's say you do all those things and you fail. Then we start, then I start talking to them about the prescription medications, because you don't want them on laxatives and long-term. You just want them on that as an as needed. So there's things such as Linzess, Amitiza. So there's prescriptions. There's a lot of different things right now on the market that can help with the constipation. But my initial approach is, what can you do in your home before jumping to medications?
Yeah, I think that's so smart. What about what are your thoughts on some of the other over-the-counter remedies like Dulcolax, Smooth Move Tea, Senecot?
Oh, yes. So I love Smooth Move Tea. I think it's great. It can really get you going. Senecot as well. A lot of times these patients have tried a whole bunch of things and they've said they failed. And I like to reinvestigate. So how did you take it? How long did you take it? Did you just try it for 2 days and you say it's a failure? So you got to do a little bit more digging, because these things work if they're taken appropriately.
Yeah.
You mentioned like diet, obviously like fiber is a big one. And for bariatric patients, it can be super difficult to get in adequate fiber because of the size of the stomach.
Yeah.
What are your thoughts on fiber supplementation?
I think, fiber supplementation is fine as long as you're getting in the right appropriate amount and you're getting your fiber supplementation from a reputable company with, not just just not anything.
Yeah. So like a Metamucil.
Like a Metamucil, Benefiber. Even people do these, you can go to, your local nutrition store and they have all these great various organic different things, because patients have certain, allergies or intolerances. So there's so many ways to get in more fiber these days than just trying to stuff your face. So we're really fortunate. It's just, helping guide the patients to the right one. And I also encourage them to bring in what they're taking so I can actually look at it myself and try to see if it's a good choice or if there's something in it that might be working against them, because, there's so much out there.
Yeah, that's so true. And when you talked earlier about the irritable bowel sometimes being related to your gut biome.
Yes.
So tell me about like probiotics, or about what is this whole microbiome you even speak of?
So in the simplest way, when I'm talking to patients in the office with IBS and about their microbiome, so it could be a imbalance of your microbiome. So there's so many things that can alter your microbiome, from your antibiotics you ate, antibiotics that you took, the diet that you're taking in. And so there's good guy bacteria and there's bad guy bacteria, and you need both. You need a balance of both. So when these bacteria get out of balance, it can lead to issues that can contribute to irritable bowel syndrome, specifically with diarrhea predominance IBS. So there's a medication that's approved for IBS diarrhea predominance by the FDA. It's called Xifaxan. And so that's to help promote an improvement in the microbiome. And you'll be surprised, you start patients on this medication, and once they take the recommended course, which is 14 days, 3 times a day, they have a resolution of their IBS, as simple as that. And you can do this course, it's FDA approved, twice during a 1-year cycle.
Wow. I'm shocked about this whole thing. So do you just assume that, okay, it's the process of elimination. That's how we got to it.
I always start with patients. I say, listen, these are the 3 things that can contribute to it. It could be 1, it could be all 3. Let's try to identify the most identifiable. Let's start with, is it something that you're eating on a regular basis that you're just not appreciating and understanding? There comes a dietitian, nutritionist, that FODMAP elimination. I have them come back. What was the results? I found something, doc. Fantastic. And then I never see them again. It's resolved. Then they say, we didn't really find anything. Okay, now we start going down that road of what else is going on. Now, is it that gut-brain axis? Is it something that you're stressed that's contributing? So we start talking about getting into tricyclic antidepressants, TCAs. We start talking about SSRI agents for the treatment of IBS, and try to identify things in their life, and then talking to them about maybe seeing a behavioral health specialist or to teach them coping mechanisms and try to identify that. And so it's just really a stepwise approach. But do you know that the number one most effective treatment in IBS, what that is?
I don't know. What?
Patient-doctor relationship. The mere fact that your doctor establishes a relationship with you, believes that you have these symptoms, is the primary number one treatment, is having a strong patient-doctor relationship.
I mean, I just want to come to you right now. I can only imagine. Are you like totally overwhelmed with your like patient load? I mean, it's just, I can see.
I mean, I enjoy what I do. Everybody, there's different people for different things. And this is what I was meant to do, and I enjoy doing it. And I love it when, initially I see IBS patients on a quite regular, frequent basis. And then we get to a point where they don't need me anymore. And that's the point.
Yeah.
If I'm doing my job, you don't need me anymore. Yeah. If you're coming back to me all the time, I'm clearly missing the boat.
Well, I do have some questions that maybe will keep people away from you in a good thing. So back to the whole, I took antibiotics and then I want a probiotic for whatever reason. Which one do you recommend? So honestly, there's so many probiotics out there, and I tell patients, they'll come in with their probiotic and I'll say, they're like, Doc, do you think this is a good one for me? And I say, wait. Have you started taking it? I started taking it. Yeah. I said, how many? There's 30 pills in this bottle. And I'm like, what I want you to do, you bought it. You paid a lot of money for it. I want you to take it for the whole 30 days. And if you notice any improvement, continue taking it. If you don't waste your money. The best, because these probiotics transiently change your microbiome. If you stop taking them, it's just going to revert back to whatever your daily lifestyle eating habits are. So the way that you actually change your microbiome is you change your eating habits and your lifestyle. It's what you put in your mouth and the choices that you make that makes the changes in your microbiome they're not transient. Wow.
Yeah, you want to give it the food that feeds that good bacteria, which is your fiber-containing foods, fermented foods.
Yes. You want to eliminate the excessive carbs that feed the bad guys. So I tell patients excess carbs feed the bad guys, and the bad guys are the ones that are the methane-producing gut bacteria. That's the one that gives you all the gas, the cramping, the discomfort.
Let's talk about gas.
Oh, yeah.
This is a favorite topic of our patients. I get this call. I've actually got this call after hours on the emergency line before that my farts stink.
Your farts should stink.
What we hear all the time is that farts are stinking. I'm telling you, I know my body, I know the way I smell, and my farts stink worse after bariatric surgery. Do you have any thoughts as to why they stink worse?
Again, here you do this surgery, you've changed the anatomy, you've changed the environment, you've changed the microbiome. And what are you putting in your body, right? What are you feeding your gut?
So if you're fresh post-op and you're no longer feeding the carbs, so actually farts smell better if you're feeding the carbs, and the bad guys smell better than the good guys, perhaps?
Perhaps. I don't really know. I haven't really done that study.
Can we do that study?
Next one. Yeah. How do your farts smell?
Fart sniffers. We need to have double-blinded placebo. Oh my God. That must be a good guy, I guess, right?
That's a good one right there, folks. That's a good one. Right? Like my dad used to say, this fart could take out an army.
I think we've all experienced someone with those farts.
Jesus, are you okay? Go to the bathroom. Yeah. My kids are ripping. Actually, I'll tell you just a little personal side note. The best poops I've ever seen. Enviable. You're talking about sausages. I'm talking about like snakes that come out, like a cobra come out. Is my 4-year-old daughter Liv.
Wow.
These poops are legendary.
They're
iconic.
I'm going to play this clip at her graduation party.
Oh my gosh.
Oh, she's going to be so proud to hear Mom say her poops are legendary.
She's told me about this before. This is not the first time that I've heard that Liv has great poops.
I mean,
they're perfect.
There's a perfect scale. Maybe Liv's poop is perfect. I'm wondering.
It's the golden poo.
The golden poop every time too. She is consistently perfect.
Well, that's the way to be. That's the gold standard right there.
Do you think it would be weird if I like posted pictures of like Liv's poops for all
versus, that's super weird.
That's super weird.
Versus abnormal. Just post the Bristol Stool Chart.
Okay, I could do that.
People would appreciate that.
Okay, we can go there. Okay, so I have a lot of other questions for you. Number one, we talked about colonoscopies to start this episode.
Yeah.
When should you get a colonoscopy?
So right now, for the general population that don't have increased risk of colon cancer or polyps in their family, the recommendations used to be 50, now it is 45. Now, if you have if there's a family history of colon cancer or polyps, then that's going to change the recommendations and the guidelines depending on when that family member was diagnosed with the polyps, and or the cancer.
Got it. And so you have the colonoscopy, let's say it's normal. When do I see you again?
So if it's normal and you're coming in for your screening colonoscopy, no family history, meaning no colon cancer, no polyps, you do your colonoscopy, it's completely normal, you're going to come back in 10 years. That's what our current guidelines are presently. Who's not to say they might change in the future, but right now it's 10 years.
Okay.
If you have a family history and you're coming in for your first screening colonoscopy and you have a family history of colon cancer or polyps and it's normal, you are coming back in 5 years, not the 10.
What degree of family?
First degree, like your mom, dad, brothers, and sisters. Okay.
And then let's say you find a polyp.
So if we find a polyp, we remove them. We send them to our pathologist. They evaluate them under the microscope and they tell us what kind of polyp it is. So if it is a benign polyp, meaning it has no precancerous features, or polyps that do have precancerous features, they'll tell us. And based on that, we'll determine when you need to come back for your next one. So, and it's also based on the size of the polyp, the numbers of the polyps found. So there's a lot that goes into determining when your next one is.
And, how often have you seen colon cancer in your career?
So I'm in the business of preventing colon cancer. So when I see the colon cancer, I would say in my career, I probably have seen 20 colon cancers.
Okay. Wow. Well, that's okay. That's reassuring, but it's also to say if you're 45,
yes,
you need to get the colonoscopy.
Yes.
No family history and sooner if not.
Yes, exactly. And I will say that what's really shocking is the ones that we do find the colon cancers in, they actually had symptoms that they just kind of thought were not a big deal, or they
what
put
are
them
the
off.
symptoms
So
then?
I mean, they had symptoms like you get into a rectum and you find rectal cancer and you say you haven't been having any like difficulties having bowel movements or seeing any blood in your stool or change in your bowel habits. Like you didn't you're coming to see me for a screening colonoscopy and I'm doing a screening colonoscopy. This is my first time meeting you. And after the procedure, finding this, and you start asking a little bit more questions like, you didn't have any, like, well, I did have changes in my bowel habits and I have been having some intermittent blood, but like it would go and come and go, So that's why we say, if you're having changes in your bowel habits that are not normal for you, if you're seeing blood in your stool, these are alarm signs. You need to let your primary care doctor know, and you need to come and see your gastroenterologist to do the appropriate evaluation and workup.
What do you think about other evaluating tools like Cologuard, Hemoccult test?
That's a great segue. So I see this happening so often. First of all, Cologuard, I see this so often where Cologuard is given to patients who they have a family history of colon cancer or polyps. That's not the appropriate screening modality in that population. What's appropriate is a colonoscopy. So that's really not appropriate. So if you have a family history of colon cancer or polyps, Cologuard is not the correct test for you. You are at an increased risk, and there's no better test than actually having a colonoscopy. Because as we know with all tests, there's false negatives and there's false positives, right? And you're already at an increased risk with regards to your family history. Also, I've seen Cologuard be given to patients that have a personal history of polyps. No, that's not the recommended use. Cologuard is for patients that do not have an increased risk of colon cancer, personally or through their family history.
So do you think it's a good screening study if you don't have any of those other things?
If you don't, like, again, it's a test, right? It has its positives and negatives. So for me, I always go with the colonoscopy.
Yeah.
I'd want somebody to actually look. The fecal blood testing, a lot of our colleagues in the ED like to do it. It's not something that we as gastroenterologists will order, but when you have a positive fecal blood test, that does warrant further evaluation with an endoscopy.
So we have a lot of our patients' anatomy's changed. We have the farts that smell a little bit different. We have some constipation.
A lot of constipation.
So I don't know how often you treat our post-op patients, but they ask a lot about, they're worried that they're going to have diarrhea, but we just don't see it much. Have you seen that?
I as well have not really seen that post-bariatric surgeries. I will see the most common patient that I see post some bariatric surgery is for abdominal pain, right? For abdominal pain. And these patients may have developed, ulcers at their anastomosis or, taking something, or they're not supposed to be taking certain medications, NSAIDs, and or drinking alcohol, and they come in with, ulcers. That's the most common ones I've seen.
Yeah, I mean, for
sure. I don't see them for the diarrhea. I don't see them for the constipation. I really don't. I really don't. Now that you make me, think about my patient population that has bariatric surgery and why am I scoping them? Obviously, the upper endoscopy for abdominal pain, and then, the patients that need their respective screening or surveillance colonoscopies.
So I think one question our patients would have in terms of having their regular colonoscopy or for these other issues, because their stomachs are so small, how do they get in? You talked earlier about the Go Lightly still being that. How do they do their bowel prep?
So bowel preps, there actually are different types of bowel preps. We talked about the Go Lightly, which is like a leader for the patients that are really struggling with constipation. But there are also more small volume preps that are out there as well. So based on your past medical history, we'll decide what's the best prep for you, right? So we could do a small volume prep as long as they're having regular bowel movements every day, every other day, feeling fully evacuated, not really having any suffering from any respective constipation. If they can't do a large volume prep, then we'll just kind of spread out when you start changing your dietary habits to promote getting things out in a timely fashion over a period of time, as opposed to trying to push it all at one time, especially when you have that, the pouch and you have your, changes in your upper GI tract anatomy.
Yeah, for sure. Now, when a patient comes in and they are experiencing some of these things like constipation and all that kind of stuff. You talked a little bit earlier. I just want to, because we get this question so much that I'm surprised you haven't seen the constipation kind of a situation. Oh my gosh,
they're all going to you.
Wow,
they're not coming to their guest.
They're going to Hannah's the expert. And so you talked about, of course, we try to do just to kind of close the loop on this because this is so common. I know that a lot of people who are listening to this episode want to know, like, how do I just have that perfect poop and how do I go there? So they're doing the things. They're drinking the more water. They're getting the fiber into their diet. They're doing some of the over-the-counter safe, non-habit forming things. And then what is your threshold, finally, for prescribing medications? And do you ever prescribe lactulose?
I believe it. Yes. Okay. So if we really tried all the over-the-counter remedies and we're doing all the right things, and you forgot to mention exercising.
Oh, yes.
Walking, movement.
I have a question really quick. What about the squatty potty?
The squatty potty is real.
It is real.
It is real. That angle, but it's a hard angle. It's kind of uncomfortable, but it does work. If you actually try, have either of you tried?
No,
you have to try it.
What's you're like leaning forward?
It's like you're leaning forward, and the position of the angle is more.
It's like a step stool.
Yeah,
that goes around your toilet,
and
so you put your feet up,
and it kind of repositions the back of your pelvis, so it gets more aligned and open things. It opens things up, so you can have.
Hannah,
hopefully,
can we do an Instagram live where you're demonstrating it?
No, absolutely not. I don't actually have one, but they do make now like pretty ones too. Like you can get like a bamboo one as opposed to like a white potty.
Really
plastic.
Yeah, but they do
heights.
work. Yeah, it does work. It changes the angle there. It opens things up for you. If you're having a bit of obstruction from your just the angularity of your anatomy of your rectum, sigmoid area.
And one other question.
Yes.
What about the stomach massage where
It
you go
works.
like up and
Yes, it works.
Because you start lower,
you should
right?
start on the right lower side and massage across. And so also patients who are like, I feel like I have so much gas.
Yes.
I say lay on your left hip and shoulder. You will pass gas. Walk will help you pass gas. Movement, it's just trapped and it needs to come out. Doing the massage will help. Stimulating. It's just, again, promoting movement in that GI tract.
Let's say you have normal bowel movements. Everything's all good there, but you just constantly have gas, you're farting, you have pain and cramping, the whole thing.
That's because you're just not moving your bowels. So back to what you were asking me. So we've done all the conservative stuff.
Okay.
We're doing the exercise. We've actually validated that you have tried literally everything over the counter, and there are patients that have, and we make sure that's the point where they're miserable. We decide to proceed with a prescription medication.
Okay. I gotta know, what percentage of the population has these elusive perfect poops? Because I feel like
I don't think anyone I've never had anyone come in and say, Doc, I have the golden poo. Just live. Sorry, that's it. She claimed it. No one else has.
Wow.
I mean, I can't even say that I have a perfect poo.
I know. I'm nervous over here. I'm like, no. I mean,
there's something wrong with me.
What's wrong with me? I'm like, I can't wait to get off this podcast because as soon as the recording goes down, I'm leaning in all right, I'm coming in. I'm not even joking.
Yeah. She's going to show up at your office.
I will. I'm like, you need to look at this.
Well, how many times have you guys had patients actually come in taking pictures of their poo and what they see so much, right? This is what's coming out, Doc.
You never do?
Mm-mm. Well, they save them for you, I guess.
I've seen for me too.
I remember one time I was at PF Chang's and I was sitting there and it was and I don't even know how they got my thing, and I look, I'm like, oh my gosh. Okay, I got it. You have diarrhea after surgery. I mean,
I know what diarrhea looks like.
What do you think this is? What do you think it is?
It's
what do you
diarrhea.
I would never forget. I can remember I was sitting and I remember being it was all up there. I can put up on the wall.
It's too close for
combo.
comfort.
Yeah, the combo there is just really unsettling. Yeah. I mean, but I guess it's a good thing that they feel comfortable enough to talk about it because
Yeah, exactly.
Everybody poops.
Everybody poops. Hot girls poop. Hot girls have IBS. It's natural. I think it's important that we encourage and break the stigma of talking about our bowel habits, right? Because there are life-threatening things that could be going on. And if you're not talking about it, then we don't know about it. So we really want to break that stigma and encourage patients to, reach out to their primary care doctors to get referred to the gastroenterologist so that we can make sure they get their appropriate evaluation in a timely fashion.
Well, and I think you mentioned earlier about having that good relationship with the patient, and that's so important. And I think it's interesting when you think about this topic is no one wants to talk about their poop, not with their friends, but then they're not even with their doctor. And your doctor's heard worse. Don't worry.
I've heard worse. I've seen it all.
Or if they haven't, it's fine because this is their job.
Exactly.
But also the population that you said it's most common in, it's women. And then when we think about IBD specifically, it is younger people. So then are we just ignoring young women and these PCPs are just like, oh, you're fine. Right. So like, no, like advocate for yourself.
Advocate for yourself. If you feel there's something is wrong, find, advocate, talk about it. If you're not getting the answers that you need, if you have a different subspecialist that you're seeing, talk to them about it. Yeah. I've had patients tell me, I tried to come and see you, but I couldn't get referred by my primary care, and my GYN referred me to you. Right? Just tell anyone if you're not getting the answers that you're looking for. Just talk about it. If you're concerned about something, if something is different that you feel is not normal, or you're hearing something on today's podcast, you're like, I don't go except for every week. That's not normal. If you're having diarrhea all the time around the clock, that's not normal. Come talk to us. Come see us. Let's help figure it out for you and get you to having that golden poo.
Oh my gosh. We should have do you have like a trophy that we can like give out?
No, I don't, but I think I need one now. Maybe I can find it on Amazon.
I mean, this is like, I know, poor Liv, but not to bring it back to Liv, but let me tell you one thing. Every time she poops in our house, our whole family, my daughter's son, she's like, I just pooped. We all like run in there because it's
so perfect.
Last night, I swear to God, Liv was like, I just pooped, and Adrian and Evan were like, okay, I need to go and look because it is like.
I hope you have pictures of this poo.
I do. Don't worry, I'm going to show you. Okay, Hannah tells me I can't put them on DoctorXDietitian.
But you can. I'm so sorry.
I mean, but we could get more followers.
I don't think we're not using Liv's poop to get more followers.
I don't think. Yeah.
Oh my goodness. Well, Dr. Case, would you help us to make some like episode guides, some like really fun things that we can put on our podcast so that people will see all that you gave us so much information.
I know we talked about so much. I mean, there's so much to talk about with poo. Like there's so many
more
things.
Questions.
You can just go on a tangent. Yeah, you can just go and go. It's
so
we
love have to have you back.
We love what we do, don't we?
Yeah, we
love
sure do. We're like leaning into these mics.
So interesting things. I was like, by the way, I have this interesting situation, and I have the opportunity to discuss it and share it with you and the audience. And so I will keep you guys afloat as to what happens with my food bizarre.
Yes.
Yeah, please do.
I don't know. This is like, I'm like, oh dear.
Oh no.
You're sure it was definitely food? You don't think
it's food? It was literally a ball of food all stuck together. All of my staff and I literally gasped. We're like, oh my gosh. And they're like, oh.
Huh.
I have seen the hair. I can't think of the name of it.
Are you sure that this patient's not doing something?
No, it's not. I've seen that. That is freaky when the whole thing comes out in the cast shape of the stomach.
Wow.
But what do I do about this food bizarre?
You might trichophagia.
What is it?
Trichophagia.
Thank you, trichophagia. But there's another name for it where it's like
trichotillomania.
Trichotillomania.
So trichophagia is the compulsive eating of hair associated with pulling hair out. And
I
said trichinosis, which I think is the foodborne illness you get from pork.
Okay, close, but it's super fascinating.
Well, you might need a surgeon to go in there, laparoscopic, make a hole, and just like
pull it out. But I may have to write it up. I'll let you guys
definitely write it up, video that, all of it.
Yes.
Wow.
Wild.
We do live fascinating lives.
We do. If we think about it, we live. Yeah, definitely. I agree. We live very exciting, fascinating lives, and it's more fascinating when we actually get to share it with one another. Because sometimes we're just by ourselves thinking about it.
I know. It's like,
these are the things that keep you up at night.
Yes, seriously.
I really was like, I need to talk to somebody about this. What am I going to do about if the food bizarre is still there when I do her EGD again?
Well, you got me on speed dial.
I know.
So you let me know.
I will let you know.
Well, we love it.
Yeah. Well, thank you so much for being with us. Everyone, check out Dr. Case on Instagram at Dr. Susan Case.
Yes.
KAIS. Yeah. And of course, we're on Instagram at DoctorXDietitian. You can also check out our website, DoctorXDietitian.com. Any final parting words for the hot girls who poop?
Listen.
And hot men, boys.
We love to hear about your poop. but nobody wants anyone riding dirty during a colonoscopy. So please take your prep accordingly. And thank you.
Oh my gosh, wonderful. Well, we will definitely check out our website, like Hannah said, because we will have plenty of episode guide. We're going to write like a 5-part episode guide on this one with all this information. But if something's not right, make sure you seek medical help always.
Yes.
Drink your water, move your legs, and get a squatty potty and be happy. The more that thing's evacuated, the better we feel.
That's right. Better out than in, as my brother would say.
There you go.
There we go. We could go all day with these things.
Right. All right. We'll see you all next week.
See you guys. Thanks so much.
Bye.
Bye.